Hi, I'm Dr. Jack West, medical oncologist in Seattle, Washington, and I wanted to talk about the recent results that came out of AACR 2018 about the CheckMate 227 trial, which is an important study that looks at the combination of nivolumab and ipilimumab, two immunotherapy agents that work at different points in the immune system and have some provocative activity in advanced non-small cell lung cancer, at least in a subset of patients defined as having high tumor mutation burden, that is, a high frequency of mutations in the cancer overall. And just by way of background, this was a study that was presented by Matt Hellman and colleagues, and it was published at the same time in the New England Journal of Medicine. It was sponsored by Bristol Myers Squibb and is a rather complex study that evolved over the course that it was being conducted. And so this is a basic summary of the original study schema. Specifically, it was designed to enroll in two large cohorts as defined by PD-L1 expression. This was in patients with squamous or non-squamous non-small cell lung cancer advanced disease as a first-line treatment, dividing patients into those who had PD-L1 of 1% or greater, who were randomized to chemotherapy doublet alone, that was histology appropriate, or nivolumab as a single agent, or a third arm of nivolumab and ipilimumab. The other cohort with PD-L1 of less than 1% were randomized in a 1:1:1 three-arm study, but a little differently. This group of patients had a control arm like the other arm of chemo doublet histology appropriate, but instead of Nivo alone, received Nivo in combination with chemotherapy, or the third arm was again Nivo and ipilimumab. Now, as the study was being conducted, the BMS folks got more and more information suggesting that tumor mutation burden may be a more valuable predictor of benefit with nivolumab, with or without ipilimumab, than PD-L1. And so partway through the trial, they defined a new co-primary endpoint of progression-free survival as but in a population of patients with high tumor mutation burden. And this was across the two cohorts of PD-L1 greater than 1% or less than 1%. And so what they ended up with from this cohort of patients who had tissue available for TMB testing and had high TMB, and I'll talk a bit more about that definition in a moment, that group of patients who had a high TMB and tissue available and were randomized to either a chemotherapy alone or Nivo-Ipi arm were compared for progression-free survival. And we heard from a press release a few months ago that this trial was positive for a PFS benefit in that subgroup of patients. So the definition of high tumor mutation burden in this setting was 10 mutations per megabase on the Foundation Medicine test. Now, interestingly, Foundation has historically defined high TMB as a less than 10% group of patients with a 20 mutation per megabase cutoff, but the BMS folks presented some data at AACR suggesting that based on some other clinical work, the key inflection point was at about 10 mutations per megabase. That represents 44% of patients. And they also showed data that highlighted that the variables of TMB and PD-L1 are really completely independent of each other. And in fact, as shown in the right side of this figure, 29% of the patients had PD-L1 less than 1%, and that was the case whether you were high TMB or low TMB. The figure in the middle just shows a complete lack of any correlation of PD-L1 expression with tumor mutation burden, just totally independent variables. So let's move on to the key endpoint that they focused on, which was progression-free survival with Nivo and Ipi compared to chemotherapy. And as you can see from the curves in this figure, the hazard ratio is 0.58, and there's a marked difference in 1 year PFS, of more than threefold difference, 13% with chemotherapy, 43% with Nivo and ipilimumab. There's also an interesting and tantalizing suggestion of a plateau as you approach 12 to 18 months, with few patients dropping. So the hope is that a subset of these patients will actually have a very prolonged benefit with this combination. In the forest plot, you can see the analysis of progression-free survival by subgroups, and that this benefit for Nivo-Ipi over chemotherapy was really seen in all of these clinically defined subgroups, regardless of age, patient sex, the part of the world where patients were enrolled from, performance status, and I'm going to show a little more about the variables of tumor histology and PD-L1 expression. Here is a figure that shows PFS by tumor histology in patients with high tumor mutation burden, and you can see there's no real hint of any difference. Striking separation of these curves for both the patients with non-squamous as well as squamous histology. Similarly, when you look at PD-L1 expression, in those patients with high PD-L1, or at least detectable PD-L1 of 1% or greater, versus those with less than 1% PD-L1, the cohort that was enrolled to that portion of the study, no difference in the benefit with Nivo-Ipi relative to chemo. It's really again, a very striking difference with a PFS over 40% in both of these cohorts. So this really seems to cut across all sorts of different ways of dividing the data. They also demonstrated that response rate was higher with Nivo and Ipi. It's not as dramatic of a difference, 45% versus 27% with chemo, but the big difference was in the duration of response in those patients with high TMB, where the duration of response of 1 year or greater was seen in 68%. So 2/3 of the patients who were responding were still responding a year in, versus only 25% of those who responded to chemo had a duration that lasted that long. They showed overall survival results, and this is just preliminary. It is encouraging, but it's not statistically significant. You can see a hint, some separation of the curves in at 1 year, 67% with Nivo-Ipi versus 58% with chemotherapy. A hazard ratio of 0.79 is certainly encouraging, but these data are preliminary. It's not a striking difference, and it's not statistically significant at this point. Interestingly, they also showed, Dr. Hellman and colleagues presented the results with Nivo-Ipi compared to Nivo alone or chemotherapy in the subset of patients with 1% or greater PD-L1. Remember that the other cohort of patients didn't get Nivo alone, but with chemotherapy. And here you can see that the Nivo alone did not perform as well as Nivo-Ipi, even in patients with a high TMB in this. So this seems to be more beneficial, particularly for the patients with the Nivo-Ipi combination. One of the big concerns with an IO-IO combination, and particularly Nivo and ipilimumab and CTLA-4 inhibitors in general, is the toxicity profile, particularly as these combinations roll out into broader use and patients who may be older and not as well selected and treated in centers where there isn't as much experience or support. And in that sense, it was reassuring when Dr. Hellman highlighted that the toxicity of Nivo-Ipi was really, I would say, a lateral move compared to chemo doublet. As you can see in the toxicity summary here, the rate of any toxicity was about the same between the two arms of Nivo-Ipi or chemo, and the rate of grade 3 or 4 toxicity also similar. Now, on the one hand, you don't get a benefit with immunotherapy of less toxicity that we've hoped for years as a promise of immunotherapy, but this wasn't a treatment that was prohibitively toxic or blew patients out of the water. And in fact, Dr. Hellman highlighted that the profile and the frequency of these toxicities was about very close to what was seen in the earlier phase 2 experience as well. I would highlight, however, that the data that were presented looked at all of the patients and not just the high TMB patients who were on immunotherapy for longer. So in that sense, the inclusion or the focus on efficacy just in the high TMB patients, but the broader inclusion of the data for toxicity in the patients who were on it for a shorter period kind of dilutes the toxicity issues and includes a lot of patients who were not as vulnerable to toxicities just because they weren't on immunotherapy for as long. So I think we need to be cautious about our interpretation of a different population for efficacy and tolerability. So these are just my initial thoughts and summary of the efficacy and tolerability. The next question is, what do these data mean in clinical practice, both now and in the upcoming landscape for lung cancer as it continues to evolve? I will be doing that in my next video, and I hope you'll join me for that. In the meantime, I would encourage you to check out other podcasts from the Beacon Medical Interchange. I hope you'll like, comment, and subscribe. I welcome your thoughts, criticisms, and counterpoints. So until next time, thanks for joining.